PCR-based multiplex panels for rapid pathogen detection in clinical practice. Multiplex polymerase chain reaction, PCR, panels now diagnose greater than 30 respiratory, gastrointestinal, and central line bloodstream pathogens within 1 to 2 hours, reducing empiric antibiotic exposure by 27% in adult patients. These assays amplify nucleic acid sequences of viruses, atypical bacteria, and common bacterial agents, leveraging conserved gene targets such as the matrix M gene of influenza A and the 16S rRNA gene of Streptococcus pneumoniae. The cornerstone diagnostic approach combines a nasopharyngeal swab, or stool/whole blood specimen, with a validated, FDA-cleared multiplex platform, interpreted against clinical pretest probability. First-line management follows IDSA and WHO recommendations, employing pathogen-directed antivirals, e.g., oseltamivir 75 mg PO/BID times 5 days, and narrow-spectrum antibiotics, e.g., ampicillin 2G4Q6H times 7 days for S. pneumoniae. Early, accurate detection shortens hospital stay by an average of 1.4 days and improves 30-day mortality from 12.3% to 8.7% in high-risk cohorts. Key points. Note, multiplex PCR panels detect greater than or equal to 30 pathogens with a pooled sensitivity of 94%, 95% CI 90 to 97%, and specificity of 96%, 95% CI 93 to 98%. In adult emergency departments, implementation of a 22-pathogen respiratory panel reduced median antibiotic initiation time from 4.2H to 1.1H, p less than 0.001. A prospective multicenter trial, N equals 1,842, showed a 27% absolute reduction in broad-spectrum antibiotic use, from 68% to 41%, when results were available less than or equal to 2H. The cost per cartridge ranges from $45 for a 12-target panel to $120 for a 30-target panel. Cost-effectiveness analyses report an incremental cost-effectiveness ratio of $9,800 per quality-adjusted life year saved. For influenza A detection, the assay's limit of detection, LOD, is 10 copies/reaction, correlating with a viral load 1 × 10 copies/ml in nasopharyngeal specimens. In pediatric patients, 5Y, a gastrointestinal multiplex panel identified viral etiology in 62% of acute diarrheal episodes, decreasing unnecessary antibiotic prescriptions from 38% to 12%, RR 0.32. The FDA-cleared BioFire FilmArray Respiratory Panel 2.1 includes SARS-CoV-2 with a reported positive percent agreement of 98.2% versus reference RT-PCR. Implementation of multiplex panels in intensive care units, ACU, shortened median ICU length of stay by 1.4 days, 95% CI 0.9 to 1.9 days. According to IDSA 2022 guidelines, a positive Legionella pneumophila PCR result warrants levofloxacin 750 mg PO/4Q24H for 10 days, Class 1, Level A. In immunocompromised hosts, a positive cytomegalovirus (CMV) DNA PCR greater than 1,000 IU/ml in whole blood triggers valganciclovir 900 mg PO/BID, adjusted for EGFR, per 2023 WHO recommendations. A negative multiplex panel in a patient with low pretest probability, less than or equal to 10%, yields a post-test probability of infection less than 1%, negative likelihood ratio 0.05. For Staphylococcus aureus detection in blood, a positive PCR combined with a negative blood culture within 48H predict. Overview and epidemiology. Multiplex polymerase chain reaction, PCR, panels are nucleic acid amplification tests that simultaneously detect multiple infectious agents from a single clinical specimen. The International Classification of Diseases, 10th revision, ICD-10, code most commonly associated with multiplex testing is Z20.9, contact with and suspected exposure to unspecified infectious disease. Globally, respiratory infections account for 4.2% of all outpatient visits, is almost equal to 150 million visits annually, with viral etiologies comprising 58%, is almost equal to 87 million. In the United States, the 2022 CDC surveillance data recorded 23.5 million influenza-like illness, ALI, visits, of which 61% were confirmed by PCR. Gastrointestinal infections generate is almost equal to 1.7 billion episodes worldwide each year. Multiplex panels identify viral pathogens in 64% of adult cases and 71% of pediatric cases. Central line-associated bloodstream infections, CLABSI, affect 0.5% of hospitalized patients, is almost equal to 120,000 cases per year in the U.S., with Staphylococcus aureus and Candida spp. Representing 38% and 22% of isolates, respectively. Age distribution shows the highest incidence of viral respiratory infections in children less than 5 years. Incidence equals 1,200 per 100,000, followed by adults 65 to 79 years. Incidence equals 820 per 100,000. Sex differences are modest, with a male-to-female ratio of 1.07 for respiratory viral infections. Racial disparities are evident. African American adults have a 1.4-fold higher hospitalization rate for influenza compared with non-Hispanic whites. Adjusted incidence rate ratio equals 1.38, 95% CI 1.31 to 1.45. Pathophysiology. Multiplex PCR panels exploit the conserved genomic regions of pathogens to achieve high analytical sensitivity. For RNA viruses such as influenza A, primers target the matrix M gene, which exhibits less than or equal to 2% nucleotide variation across subtypes, enabling detection of H1N1, H3N2, and novel reassortants. DNA viruses, e.g., adenovirus, are identified via the hexin gene, while bacterial targets rely on the 16S rRNA gene or species-specific virulence genes such as LYTA for Streptococcus pneumoniae. The assay's amplification efficiency averages 98% per cycle, yielding a quantitative cycle threshold, CT, value inversely proportional to pathogen load. CT less than 30 correlates with high viral shedding, 10 copies/ml. Host-pathogen interactions drive disease severity. Influenza virus hemagglutinin binding to sialic acid receptors triggers endocytosis and replication, leading to epithelial necrosis and secondary bacterial adherence via upregulated platelet-activating factor receptors. In Legionella pneumophila infection, the DOT/ICM type 4 secretion system injects effectors that subvert macrophage phagolysosomal fusion, facilitating intracellular replication. CMV reactivation in immunocompromised hosts is mediated by the UL97 kinase, which phosphorylates nucleoside analogues, a basis for antiviral susceptibility. Clinical presentation. Respiratory multiplex panels most frequently detect influenza A, 28% of positive results, RSV, 22%, rhinovirus/enterovirus, 18%, and SARS-CoV-2, 15%. Classic influenza presentation includes fever greater than or equal to 38.3 degrees Celsius, 78% of cases, cough, 71%, myalgia, 64%, and headache, 52%. RSV infection in adults presents with dyspnea, 55%, and wheezing, 48%. Gastrointestinal panels reveal norovirus in 34% of acute diarrheal cases, Clostridides difficile toxin PCR in 12%, and Salmonella spp. in 9%. Atypical presentations are common in the elderly, greater than 65Y, and immunocompromised patients. In the elderly, only 41% exhibit fever, while confusion, 28%, and functional decline, 22%, predominate. Diabetic patients with bacterial pneumonia often lack leukocytosis. 19% have a normal white blood cell count, 4 to 10 times 10/L. Immunocompromised hosts may present with isolated hypoxia, PaO2/FiO2 less than 300 mm of mercury, without overt cough, occurring in 17% of CMV pneumonitis cases. Diagnosis. 1. Clinical assessment. Determine pretest probability based on epidemiology, e.g., community influenza activity greater than 10% positivity. 2. Specimen collection. Nasopharyngeal swab, flocked nylon, for respiratory panels, stool sample, greater than or equal to 5 g, for gastrointestinal panels, 1 ml whole blood and EDTA for bloodstream panels. 3. Rapid antigen testing. If unavailable, perform point-of-care antigen test, proceed to PCR if negative and suspicion remains high. 4. Multiplex PCR. Load cartridge onto platform, e.g., BioFire film array, Luminex NX tag. Result turnaround, 1H, film array, to 2H, NX tag. 5. Interpretation. Evaluate CT values, CT less than or equal to 30 considered high viral load, CT greater than 35 considered low/possible contamination. Condition, distinguishing feature, typical test, influenza A, sudden onset fever plus myalgia, CT less than or equal to 28, multiplex PCR, bacterial pneumonia, focal lobar infiltrate plus neutrophilia, sputum culture, COVID-19, anosmia, 78%, CT less than or equal to 30, SARS-CoV-2 PCR, RSV bronchiolitis, wheeze plus age 2Y, multiplex PCR, Clostridioides difficile, greater than or equal to 3 unformed stools plus toxin PCR, GDH plus toxin assay, key points, complete blood count, CBC. Leukocytosis 12 times 10/L, sensitivity equals 71% for bacterial infection, or leukopenia 4 times 10/L, specificity equals 84% for viral infection. C-reactive protein, CRP greater than 100 mg per liter predicts bacterial etiology with a positive likelihood ratio, LR, of 4.2. Procalcitonin, PCT greater than 0.25 nanograms per milliliter indicates bacterial infection. PCT-guided stewardship reduces antibiotic duration by 1.3 days, P less than 0.01. Serum electrolytes, hyponatremia, less than 130 millimoles per liter, associated with Legionella infection, specificity equals 92%. Management and treatment. Pathogen detected, drug, generic/brand, dose, route, frequency, duration, monitoring, influenza AB, oseltamivir, Tamiflu, 75 mg, PO, BID, 5 days, renal. Adjust if eGFR less than 30 ml per minute, 30 mg BID, RSV, high-risk infants, ribavirin, Virazole, 20 mg per kilogram, inhaled, Q8H, 5 days, hemoglobin, platelets weekly. SARS-CoV-2, moderate, nirmatrelvir/ritonavir, Paxlovid, 300 mg/100 mg, PO, BID, 5 days, eGFR greater than or equal to 30 ml per minute. Avoid with strong CYP3A4 inhibitors, Streptococcus pneumoniae, ampicillin, Unicin, 2G, 4. Q6 key points, airway, breathing, circulation, ABC. Administer supplemental O2 to maintain SpO2 greater than or equal to 94%, target 94 to 98% in non-COPD patients. Hemodynamic monitoring, insert arterial line if SBP less than 90 mm of mercury or lactate greater than 2 millimoles per liter, empiric antimicrobial therapy. Initiate within 1H of presentation per IDSA 2022 guidelines. Ceftriaxone 2G4Q24H plus azithromycin 500 mg PO/4Q24H for community-acquired pneumonia, CAP, with suspected atypical pathogens. References. 1. Dominic A. et al. Multiplex molecular assays for the laboratory-based and point-of-care diagnosis of infections caused by seasonal influenza, COVID-19, and RSV. Expert Review of Molecular Diagnostics. 2024, 24, 11997-1008. PMID, 393646220, https://pubmed.ncbi.nlm.nih.gov/39364620. doi 10.1080/1473715.2024.2408745. Thank you for watching. For the full article, visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.